what sort of what level are people at? Are they what sort of stage of medical school are they at?
I think most people are in their clinical years, but I'm not entirely sure because it's like a sign up, so they can just join if they want to.
I don't
Uh,
know what.
I
Okay,
think,
be a variety of
yeah,
people. Okay, fine. Okay. I guess people can just interrupt me. Obviously, normally these lectures are always in person, so it's like slightly less interactive because it's obviously online, but people are very welcome to just interrupt me, particularly if it's not um, very clear. Oh, sorry, someone's just trying to phone me from work. Just give me 2 seconds just to answer this call. I'll be just 2 seconds, all right?
yeah, it's all right, no worries.
Um, Sorry about that. Sorry, that was something just semi-urgent. Right, let me just try and share again, shall I? Okay, can you see this? Can someone tell me whether they can see this screen again?
Yep, it's working.
Yeah, yeah, cool. Okay.
Yep.
Right. So people, as I say, can just interrupt me. I'm just going to give you the lecture that we would normally give in the kind of fifth year Oxford University lecture, which is basically for people who haven't done any specific acute pediatrics yet, and we're trying to give them a flavor of how to approach the febrile child and thinking about the kind of different clinical phenotypes, and then a bit more about the background of why that's important in terms of the need for vaccination to prevent many of these types of severe infections. So, I'll go over kind of clinical approach to children and how that's different from adults, thinking about specific things you should worry about if you've got a child that's presenting with fever, i.e., red flags, some basic biology of what is involved in immunity, both innate and adaptive immunity, it's non-specific cellular and humoral immunity specifically, and then the vaccine schedule, which I guess will maybe be slightly less relevant to a population of students that are outside of the UK, but at least it can give you a framework of what our current schedule is, why it's important, in our opinion, to vaccinate, and the kind of problems that were surrounding that at the moment. Some of the side effects, the perceived risks of side effects, and the realities of that, and then the very rare reasons when we sometimes actually can't vaccinate. So, um, in terms of immunity itself, obviously it's kind of very broadly, this is a gross simplification, but it's broadly thought about as an innate, kind of non-specific, unthinking early recognition of any type of pathogen. It's not focusing on a specific type of pathogen. You kind of think about that in some ways like your front line of your army, the kind of most junior guys who are kind of fairly unsophisticated, but they're rapidly available for attention. So the neutrophils, the kind of white cells that become very rapidly expanded in the bone marrow, and similarly macrophages, which are important in a kind of non-specific response, both in the bone marrow but also in specific tissues. And they can signal also in this kind of orchestral way towards cytokine activation and complement activation. So that's the kind of first line defense, innate immunity. And then on the other side, you have adaptive immunity, which is specific to the individual pathogen, be that a bacteria, virus, fungus, parasite, uricate, whatever it is, it's thinking about that specific bug. And that's often a memory response. So that's often if after you've had your first infection with that pathogen, you get a secondary memory, and we'll go into the details of how that's organized in a moment. But when you think about the different types of immune architecture, it's T cells and B cells that are on that side of the kind of adaptive side of your immunity, and specifically B cells that stimulate antibodies in the secondary response, where you have kind of lasting memory, and so you kind of dampen down the infection the second time you interface with it. So um, that's just to give you the overview of the innate immunity and how that in this picture here is illustrating how you get a very quick but kind of non-specific response to an infection, and then the subsequent infection where you get this adaptive, more focused pathogen-specific response. So children get febrile all of the time. So the average kid, a normal immunocompetent host, gets a fever between about 9 to 12 times a year. And fever is actually a very beneficial inflammatory response. It stimulates a whole raft of different kind of immunomodulatory signaling. So just by the nature of having a fever, you'll drive that huge release of neutrophils, those kind of frontline defense white cells, both the increased population of them in the bone marrow and then the stimulation of them into the kind of peripheral tissues where you think the infection is. It also increases major histocyte complex 1 and 2 pathways, and that's really important for kind of antigen presentation, and then your kind of adaptive immunity to deal with those antigen presentations and dampening down infection. Fever also actually improves the efficiency of phagocytosis, so the various different innate cells that eat up different bugs, that's driven by a fever. And it also can inhibit the growth of microorganisms themselves, so it can reduce the amount of growth of a bug that's trying to replicate in the body. And it actually also augments the efficacy of drugs that we give. So fever is actually a very important messaging aspect of illness. So I'm going to kind of go through the kind of basics of what you need to think about when you're approaching a child with fever. And you should always remember that fever is not always caused by infection. I think obviously about 55% of admissions to UK hospitals are driven by a primary infection, but actually you've got to remember that there's lots of infection mimics, malignancy, inflammation that can be rheumatological or immune mediated, or there's a whole raft of things just to keep at the back of your head. Don't always just assume something is infection, although that being said, I'm about to speak about nothing really apart from infection for the next hour. So I just kind of want to give people a flavor of, obviously you get a whole raft of different types of presentations with fever into children of different ages, and what you should and what you shouldn't worry about immediately when you see a child who presents the accident and emergency. So here's four clinical scenarios, and maybe people would just pitch in with which of these children they think they would be worried about. So the first child in the top left is a 9-week-old baby who's been unwell for a couple of days, crying more than usual, not breastfeeding as much as normal. Mum's noticed a fever by using a forehead thermometer, and she's phoned an ambulance. Would people be worried or not worried about this first infant? Anyone can say whether you, and there's no right answer. Just tell me whether you are or whether you're not, and why. I can't hear anything. I don't know if that's just people aren't willing to speak or because I've got a problem with my sound. Carla, can you hear me?
Someone in the chat just said that they would worry.
They would worry. Okay. Yeah, fine. Yeah. So you're right to worry because it's an infant, okay? But actually there's lots of red herrings here. So this temperature is you don't know whether it's real or not because it's a thermometer on the forehead, which is basically a random number generator. So for infants, you want a sublingual or an axilla measurement. So you don't actually know whether that fever is real, but certainly you would think about it in a 9-week-old, you would be heightened because their immunity is incomplete. It's not at its might be worried about this child just by the nature of their age. So then there's a 2-year-old girl, snotty, coryzal, feverish for 4 days, who's got a high temperature, and mum's worried it's feverish. And the reason she's worried is not necessarily because of this specific fever, although it's high, it's because it's the fifth febrile illness in 6 months. So again, would people be worried or not worried about this child on the bottom left? And Carly can shout out if I can't read what's being said.
Yeah, people in the chat have said they'd be worried.
Okay, so I'm totally not worried about this kid at all because, as I've just said, at this age, nursery school child, I'm not surprised that you'd get fever up to monthly, actually. So this child, with this limited story, I'm not particularly worried about, actually. So that's a kind of important point that the number of illnesses aren't necessarily that concerning. And then a 6-year-old boy in the top right, who's been unwell for a couple of days, coughs not. Again, he's got a really high temperature by that forehead thermometer. Um, are people worried about him?
Someone said they'd be worried because the fever is too high.
Yeah, okay, so that's a good. I'm trying to catch you out with that. So actually, there's huge inter-rater variability in terms of temperature. One person's 40.1 is not another person's. So actually, some people are just naturally very hyperfebrile, and that in its essence doesn't make you more likely to have severe disease. So actually, the height of the temperature isn't so concerning. It's more about the pattern in terms of how you persistently febrile despite antipyretics, which leads nicely into the next scenario. So, 5-year-old boy who's been unwell for nearly 2 weeks, but then in the last sort of 24 hours, he's got a new rash. He's been febrile for 6 days, and that's despite antipyretics, so with Calpol or paracetamol, as you'd want to call it. Are people worried about him?
Yes, we should really think about Kawasaki.
Yeah, yeah. I think of all of these children, he's actually the one I'm the most worried about. You're absolutely right. Persistent fever despite Calpol, and he's got a new acute rash. So he's the one I'd probably be rushing into the high dependence unit for an assessment. So just to give you a real flavour before we go into the delves into individual aspects of individual kind of clinical phenotypes, that fever can present in a whole vast number of different ways. And actually, as an isolated feature, it's pretty unhelpful. It has to be as part of a constellation of different interpretive symptoms and signs. So, is it a persistent fever? Is it responding to antipyretics? How long has it been going on? What symptoms are associated with it? How old is the child? Are they immunocompetent? There's so many other things you need to consider outside of the fever itself. Okay, so obviously, as for adults, you need to think about it in the same way. You have to be systematic with an A, B, C, D, E. There's published data that are kind of population-based science on how you can extrapolate whether someone is unwell acutely at the front door based on clinical symptoms and signs. And there's things such as the NICE traffic light sign to decide on whether you need to be treated immediately by a clinician, whether you can wait in the A&E department. There's things like the PEWS, which is the pediatric early warning scores, where people can be monitored when they're in hospital to determine whether they're deteriorating and identify features of invasive septic-like episodes early. And then there's certain things that should immediately make you worry before you even lay a hand on the child, things that make you at increased risk of severe disease. And these include being febrile for an infant that's certainly under 3 months because of the immaturity of your immune system. If you've got those classical warning signs, like I just described, a high PEWS or a septic score, a non-blanching rash by definition to make you worry, persistent fever for more than 5 days, if you're really not eating and drinking. And then, of course, you've got to think about kind of B symptoms. So, systemic weight loss, night sweats, lymphadenopathy, hepatosplenomegaly, and that may be TB, but it also might be malignancy. So, any of those things should immediately make you worry. So, the thing I think is quite nice about pediatrics, it's different to adult medicine, is that it really genuinely is much more clinically focused in terms of we make a lot of decisions without having to draw bloods and do x-rays. And I think that's a really nice nature of the kind of clinical practice. You really use your clinical skills. So I'm going to start by just going through all of the kind of clinical different phenotypes that we see most frequently in acute general pediatrics related to infection. So the most common thing you're going to see in a child, certainly preschool age or toddler age or nursery school age, is a viral upper respiratory tract infection. So the kind of history of that is often it's fairly short. They can often be fairly febrile, they're snotty, they can have a dry cough, hoarse cough. Very frequently, they don't want to eat and drink because they've kind of got pain in their upper airways. Importantly, that fever is controlled by Calpol. The really important question to ask when you're assessing those sorts of children in the history is there a sibling who's unwell and how old is that sibling? It's so often the case that you'll have either a school age child who's got a nursery school sibling who's been unwell for the last couple of days or vice versa, and it's kind of transferring around at the house. Clinically, they present often with a kind of erythrodermic, widespread blanching maculopapular rash. They'll be snotty, they'll be coryzal. They've got small lymphadenopathy or no lymphadenopathy. They might have a red throat, but it's not got pus. If they've got sore ears, they might have slightly retracted ears, but they don't have pus behind that tympanic membrane. And this is the kind of daily bread of general pediatric assessment in the ED. This child I'm describing, of which you'll see thousands in your career, is a clinical diagnosis. You don't need a chest x-ray, you don't need to do bloods. You can be quite confident with this kind of clinical picture, particularly when they've got responding fever to antipyretics, that this is a viral irritatory. It doesn't need any further investigation. And as long as they're not needing oxygen or they're not got very severe respiratory distress, they can go home. A caveat to that is there are some particular viruses, such as the enteroviral family, that can give you a non-blanching rash. Any child that has a non-blanching rash requires investigation. So even if you're fairly confident if you're this kind of well experienced in pediatrics, you think you can define a viral non-blanching rash, you'd be foolish to do that. You just have to do the baseline bloods for clotting and PCRs for meningococcal because you can't really delineate that with any certainty. So that's the one caveat to that kind of clinical phenotype. Back to your tonsillitis, this is the bane of my existence. It's so frequent that you'll see children actually who get as far as having seen the GP, then they'll come to a clinical decisions unit, they see a general pediatrician, then they'll come to see pediatric infectious diseases, and all that they have is a tonsillar pus process going on that's given them a hyperfebrile picture. But the reason there's been such a legacy of them taking so long to get to you and get a diagnosis is no one's looked in the back of the throat accurately. It's hard, I accept that in young children it can be hard to do a throat examination, but it's so critical to just make that your routine practice because it saves so much time and effort for other people. So back to your tonsillitis, it very classically gives you a really, really high temperature. It's a very kind of pyrogenic process. Again, it gives you that hoarse cry, sore throat, very reluctant, very, very painful. You get halitosis, high fevers, and it can be recurrent in some children. Again, the examination has got, as I say, kind of pustular tonsils, with kind of often very significant bilateral cervical lymphadenopathy. It looks a bit like this horrible picture here. But critically, even with a child who's got a temperature of 41, if you find that in the back of the throat, that's your diagnosis, that's your source of infection. You don't need to do anything more in terms of bloods or investigations. You can get a week of penicillin V or amoxicillin and go home. Similarly, otitis media, which you certainly see in toddler age children, again, high fever, short duration. The classic thing in the kind of toddler ages or even the preschool children is you get this painful process, which is making them pull at their ears or play with their ears, finger in their ears. And that's a kind of really important thing to ask about specifically in the history when you examine and assess any acutely unwell child. Again, it can be recurrent. And the classical thing is when you look in the back of the ears, in the ears with a tympanometer, you can see this kind of angry bulging eardrum, which can be fluid filled with pus behind it. If you're really unlucky and it's been there for some period of time, where there's been a significant pressure change, such as with air travel, you can get a significant otitis media rupture. This is a kind of classical picture where it's not ruptured, but you've got that kind of dense, fluid filled and slightly pus filled tympanic membrane. And again, it's a clinical diagnosis. You can look in the back of the ears, you can assess them and make that decision. You can give them oral amoxicillin or penicillin and send them away. In contrast to that, lower respiratory tract infections such as bacterial pneumonia, this is an important thing to be able to, again, use your clinical skills to delineate from viral irritants. So a bacterial process is generally got a focal component. So even in the young children, you'll find for a bacterial process in the lung, there'll be one area that has got crepitations rather than a bilateral kind of wheezy expiratory sound, which you get much more frequently with viral urtes. The other thing that catches you out with little children is they can often have very non-specific or actually distracting features with their LRTIs. So they can actually complain of lower abdominal pain, which is actually referred pain or misunderstood pain from their peripheral pleuritic infection from the lung. The key thing is, not always, but I would say most of the time, these children aren't coryzal. If you've got a pure bacterial lower respiratory tract infection, they don't have snot coming out, and they've got those focal crepitations. The caveat to that, I would say, particularly at this time of the year, is when you've got influenza upticks or other viral upticks at periods of time in your winter in your relevant country. Actually, the definition of having a viral low respiratory tract inflammatory process going on leads to epithelial damage, and you can get secondary bacterial processes that spill over into the lung. So it's not an absolutely fundamental exclusion criteria if you're snotty, particularly in a kind of high late autumn, early winter process epidemiologically. But most of the time, people with bacterial pneumonia don't present coryzally. I guess fundamentally, for those that have done no pediatrics, a very simple way of thinking about pneumonia that's a bacterial process is it's almost always unilateral and focal. So it's one side and one aspect of one lung, as opposed to that kind of diffuse viral process that's throughout both lung fields. And again, unlike in adults, lower respiratory tract infections is a clinical diagnosis in pediatrics. If you find focal crepitations, you've got your source of fever, if they're not requiring oxygen, not in lots of respiratory distress, they can have oral antibiotics and they can go home. Urinary tract infections, again, is a really, really common presentation in pediatrics, particularly in the young infant ages, certainly under 3 months of age. And if you're under a month, because of the kind of lack of fully formed blood-brain barrier, there's a really high risk of spillover into the brain, and that's the primary source of meningitis in neonatal infants. So if you find a UTI in a baby that's under 3 months and certainly under a month, they need a lumbar puncture to exclude bacterial meningitis. But think about the UTI itself, it's often very non-specific in pediatrics. Children don't come in saying, I've got burning pain with my wee, particularly if they're under 5. They often are really unsettled. They're really grizzly. They don't want to sit still. They're often playing with their underwear because they're really, really disgruntled with the pain. The urine can be very foul smelling. It can look like this kind of thick, purulent urine if you manage to capture it. Again, they can have increased frequency of their urine. They can end up with bedwetting, which if they're a child that's normally dry at night, that can be a kind of cardinal feature. And abdominal pain can be a symptom, but not always, depending on the age of the child. Again, it's very straightforward to diagnose as long as you can get a clean catch urine. Please don't ever try and do urine samples from catheters because they will always be contaminated. You shouldn't need to do a suprapubic aspiration. It's just about waiting with time and making sure that the parents are vigilantly trying to capture a clean catch urine. And once you've done that, you can send it off for microscopy and culture and get your diagnosis. Gastroenteritis, similarly, is a very, very common presentation in pediatrics. Diarrhea and vomiting, particularly if you're nursery age and there's lots of outbreaks, and particularly in the autumn and spring months. Classical presentation, tummy pain, vomiting, fevers, diarrhea. Always ask about recent travel. Always ask about unusual foods. Always ask if there's other members of the family that have got the same process going on at the same time. I used to work in Malawi, and sadly, this presentation would not unfrequently lead to severe morbidity and death simply because of the level of dehydration. Children become profoundly dehydrated very quickly, and actually you can end up with a very catastrophic secondary hyponatremic process or hypernatremic process, depending on where the fluid loss is from in the cells or extracellularly. So you have to be really, really vigilant if children have lost lots of fluid quickly to monitor their electrolytes and make sure you optimize their supplementation. In most children in a kind of low middle income setting, this can be hard to do if you've got limited diagnostics. But in high income settings, we should be able to monitor this quite easily. And again, a mistake that's always made is people want to get a pathogenic diagnosis. You just don't need to for gastroenteritis unless you've got very, very persistent, and by that I mean more than 10 days of diarrhea, or you've got significant dysentery, lots of blood in your stool. It's a self-limiting process, irrespective of whether it's bacterial or viral. You don't need an MCNS. You don't need OCPs. You don't need to look for parasites or unusual things. It's just a case of time. Chickenpox, we're at a really interesting time with chickenpox in the UK because the vaccine is just coming into licensure in the UK next year, which means we'll just all of a sudden see a dramatic drop in this presentation. I'm sure plenty of you will have seen family members or even in the hospital people with chickenpox. So it's a very, very highly infectious virus. It's one of three only airborne infections that we know about. The only other ones are measles and TB, which makes it have a very, very high attack rate. So if you're in a room for more than 15 minutes with another child or adult that has got a primary eruption of primary chickenpox, you've got an 85 to 90% chance of having a eruptive process yourself because it's so highly infectious. It's got a very non-specific prodrome, so it's really hard to know when someone is in their effective period. You can be flu-like, have poor oral intake, and then you end up with this eruptive blister and pustule-like rash, which is centrifugal, so it starts centrally and then moves peripherally. You can have a low-grade fever. It shouldn't last more than 5 days. If it does last more than 5 days, you have to think about secondary bacterial infections. Unfortunately, children still to this day die of secondary bloodstream and septic shock picture from group A streptococcus and Staph aureus, with the bacteria getting into the kind of wheals and open skin breakdown from the chickenpox lesions themselves. So always consider secondary bacterial infection. And you also have to remember there are other less frequent presentations as complications with chickenpox. So severe Staph aureus or group A streptococcal pneumonias. You can get cerebralitis. We can get in a kind of parainfective process that causes um, ataxia. You can also end up with diffuse primary encephalitis, where the virus actually escapes into the parenchyma of the brain, which can be catastrophic. So whilst for 99% of children, it's a kind of fairly self-limiting, although albeit painful infection, you have to think about those secondary complications of this disease. And then I'm not going to spend lots of time individually going through all of the other subtypes, but there are other obviously organ-specific causes of pediatric fever that you should think about. Cellulitis is a fairly easy diagnosis to identify. It's a kind of classic erythrodermic evolving inflammation of the subcutaneous and deep tissues. Septic arthritis, osteomyelitis. Again, if you're an older child, that's a fairly straightforward process to diagnose because children will tell you they've got a long bone pain, they've got pain when they're moving their hip or their knee or their ankle. But in younger children, it presents much less specifically. Often it'll be a subtle progressive limp, or they'll be not willing to weight bear. And you have to have a kind of high index of suspicion with this presentation. And then meningitis, again, whilst people think of it as a very classical paradigm of photophobia, headaches, neck stiffness, when you look at the epidemiological studies, particularly in young children, those symptoms are actually not often there. They're often very non-specific. About 40% of neonates and infants have no symptoms apart from fever. So you have to have a high index of suspicion again. Okay, and then there's the non-infective processes that you should consider in pediatric fever as well. So Kawasaki's disease, which is a constellation of different presentation symptoms of a persistent fever of 5 days or more with non-purulent conjunctivitis. So red eyes, but without the associated pus. Bilateral peripheral cervical lymphadenopathy, this classical erythrodermic maculopapular rash. You can get this classical strawberry tongue, where your tongue actually has the features of looking like a strawberry with those kind of seed-like evolutions of your tongue itself. And then you secondarily get this later stage, week to 10 days, edema, peripheral peeling of the skin. So that's a very important medium cell vasculitis, but it's a very good mimic of lots of acute pediatric infections. And unlike acute infections, it needs immunomodulation. You need to give steroids. You need to give aspirin to protect the vasculitis that's going on in the cardiac vessels to prevent aneurysm. So it's an important thing to consider as a mimic in children with fever, because if you miss it, you can end up with very significant cardiac dysfunction lifelong. And then, of course, there's a whole range of other non-infective processes, like I mentioned at the beginning of the talk. So, juvenile idiopathic arthritis, rheumatological driven inflammatory processes. Similarly, multi-organ rheumatological diseases like SLE, so systemic lupus erythematous. Malignancies often present very, very similarly to pediatric infection. and then periodic fever syndrome, so hyperinflammatory or dysregulatory inflammatory processes that I don't think you need to spend too much time to consider in detail, apart from to just think that there may be a non-infective process going on with a child with fever. Okay, so in terms of where we're up to, that's us kind of gone over the kind of very classical clinical presentations. I don't know if anyone has a specific question about anything of any of those slides, or whether you're happy for me just to carry on to start talking about vaccination and how we manage and reduce the burden of infection. I can't see the chat, so I can't see if people are asking anything.
No one said anything so far.
Okay, I've just seen there's 50 people listening. And can I ask, are the vast majority of people, are they physically in Palestine, or are they actually people who are linked to people who are in Palestine? Just in terms of, I'm conscious that it's like, I think it's 10 p.m. there, right?
I think we're in Palestine, and it's 10 p.m.
Yeah, it's late. It's late.
Yeah.
It's certainly late to be listening to lectures. But okay, I'll probably talk for like another half an hour and probably leave it there because it's pretty late, isn't it? Is that okay?
Okay, tomorrow's Friday, so I think yeah, we don't mind. I think most of the comments in the chat are saying that it's okay. So
Yeah, it's worth it.
yeah.
Okay, fine, fine. Okay, that's great. Well, if you've got any specific questions, just ask me. But okay, right. So I'll carry on. Okay, so now coming on to like going on beyond clinical phenotypes and the presentations to expect, I guess thinking about what we've done to try and deal with reducing the burden of infection. So clearly, we've just had a horrific global pandemic, which was, completely unexpected, and 90 million people have died, and it's been a complete catastrophe in some ways, but it's not a new story. We've been dealing with various different iterations of plague and influenza that have also killed millions of parts of the international population. And so we've kind of been in this lifelong battle as a species of human versus, epidemic or pandemic infection. Now, there's been a significant reduction in pediatric mortality internationally in the last 30 years. Some of that, of course, is vaccination, but there's other really important public health measures, so sanitation, improved nutrition, or other really key influential things that have improved child health. You can see that vaccination is undoubtedly, I would say, the biggest public health intervention that's improved child health in the last 100 years. If you look at these modelling studies alone, if you look at reduction in infant mortality that's attributable to vaccination in the last 30 years, as a singular intervention, it attributes 40% of all changes in child health. So that's pretty impressive figures. So I'm just going to go through in fairly basic terms about the ways in which we utilize the underlying normal physiological biology of the human host to augment that through vaccination to kind of mimic a primary infection to prevent a secondary infection when you first interact with it in the population, causing severe disease, if that makes sense. So, in a very simplistic way, I'm just going to take you through the adaptive arm of the immune system and thinking about specifically T cell responses to infection. So, I'm going to start with the CD4 helper cell. So, the CD4 helper T cell is clever because this is the non-self, the antigen that's been causing mischief, be it a virus probably, or a bacteria, or even alternative things like fungi. You have these various different policing white cells, could be a macrophage, could be a natural killer cell, could be a neutrophil, who gobble up either a part of that bacteria or virus or the whole thing and basically chop it up into pieces within that white cell that's presenting as a kind of policing cell. And it presents part of that antigen structure onto the cell surface. And it does that by utilizing the major histocompatibility arm, as you can see here. Now, CD4 helper T cells like binding to MHC class 2. So when you've got an antigen presenting cell, like I say, it could be a dendritic cell, a natural killer cell, macrophage, whatever that sort of policing cell is, it will present this part of the antigen onto the surface by the MHC2 class. And then the CD4 helper cell comes along and says, here's something I don't recognize, I don't like it. And you get this cacophony of secondary immunological kind of downstream activation. So CD4 helper cells, by the definition, they're helper cells. They're not like the cytotoxic T cells who can drive cellular death by themselves. But what they do is they identify this abnormal non-self antigen and they stimulate a number of different phagocytic killing cells, and that can often be stimulated in part by cytokine-driven immunosignaling to say, this is a non-self, we need to get on top of this quickly. So they get all these various different helper molecules, like I say, it's interleukins, i.e. a different word for cytokines. They recruit B cells to come along to then have a stimulation that will lead to a secondary humoral immunity. So the CD4 helper cell is very important in first recognizing that non-self and causing this kind of orchestral secondary response where it calls in all of its friends to come and help try and deal with this problem of the non-self. That's in contrast to the other very important T cell that's important for the adaptive side of the lymphocytic architecture of the immunity, which is the CD8 cytotoxic T cell. So similarly, whether this is a different dendritic cell or macrophage, whatever this policing cell is that's gobbled up this non-self antigen, this time the non-self antigen is presented on a MHC class 1 arm, and when that is presented, it's the CD8 cytotoxic T cell that binds to that. Same process, you get the attachment, you get the activation, but the fundamental difference here is, as is the clue with cytotoxic, the CD8 T cell has the ability to kill that pathogen there and then. So what typically happens in normal human biology is once a cytotoxic T cell recognizes the non-self, there's two different types of proteins that are really critical here. There's perforins, and as the kind of word alludes to, perforins actually can burst holes into the wall that's presenting these non-self antigens. And those little holes that are made allows a secondary protein called granzyme or granzymes to then enter into that cell, and that leads to a programmatic cell death. So you get the activation with the CD8 cytotoxic T cell. That secondarily leads to perforins entering that cell. The granzymes then get through those holes that the perforins have created, and you get secondary programmatic cell death. So other aspects of the immunity that are really important are you don't just want cellular focused cell death, you want to create a memory recognition of that non-self antigen. So the next time you interface with it, you end up having a lasting, more rapid, more considered, broad response immunologically. So for example, if you've got an activated helper T cell, like I was talking about before, the CD4, using a different binding arm, the CD440 ligand, this can attach to B cells, and B cells recognize that they're being stimulated. They then vastly and very quickly produce plasma cells. Plasma cells can then go on to do a number of things. They can produce antibodies that can then stick onto the pathogen and cause more immunological signaling to cause cell death. They can cause stimulation of natural killer cells to come and attack the non-self antigen to die as well. So that's what plasma cells do acutely during that acute presentation of the infection. Alongside that, B cells aren't just thinking about the acute infection with plasma cell stimulation and secondary antibody response. They're also thinking about how we're going to memorize and log this infection so we're ready next time and have our whole army ready to deal with this infection. So in addition to B cells stimulating plasma cell populations very quickly, they also produce large amounts of memory B cells. And those memory B cells are critical because they are the architecture that has the cadre of pathogen-specific antibodies. So once you have your primary infection, your memory B cells get stimulated and then they get stored in various compartments in lymphoid tissue, in the bone marrow, and they also then have the antibody response ready to go. And so you've got vast numbers, billions of individual pathogen-specific antibodies that can then be stimulated immediately the next time your body interfaces with that pathogen to kill them and prevent a kind of significant secondary infection the next time you face that specific bug. Okay, so that's the kind of underlying biology, and I think that's important to labor because it makes you think about what's going on when we vaccinate and how we're dealing with different bugs when we interface with them. So in terms of immunity, you've got two broad types of immunity. You've got passive immunity, and if you think about ways in which you can have passive immunity rather than active immunity, one key thing is if you have a synthetically produced antibody bag, for example. So a good example of this, I think, for people that aren't experts in immunology or infection, are children who, for whatever reason, have a primary immunodeficiency, of which there are hundreds. But often, if you don't have the ability to produce antibodies, often because you can't produce, you've got low numbers of B cells, then you can be at risk of invasive infections because you don't have the antibodies to deal with those infections. So one way we overcome that, for example, with a thing called XLA, so X-linked A gamma globulinemia, which is a very long-winded way of saying I don't have any IgG to deal with infections. We then actually give synthetic bags of pooled people. So what these it's called intravenous immunoglobulins, and the way that these are made is that they pool tens of thousands of willing participants who give their own antibodies, and that gives you a wide spectrum of different vast numbers of antibodies to various different types of infection. So you're passively inducing immunity into a child who has no ability to produce their own antibodies. So that's a fairly rare thing, but it's a very important principle that you can induce passive immunity by giving people other people's antibodies in essence. By doing that, you obviously aren't producing any memory, you're just giving synthetic replacements. So you're not going to continue to produce long-term protection because you're not driving your own antibody responses, so it's synthetically replaced. And that's fundamentally contrasting to active immunization. So active immunization is whether you either have an active interface with an acute infection the first time you deal with the infection, and you get that long-term secondary immunity, as I described in the last slide, where you stimulate B cells and B memory cells and then secondary antibody memories. Or alternatively, instead of an active immunization by primary infection, you can actually synthetically mimic a primary infection by administering a either an entire pathogen or a pathogen component or a part of the protein structure to basically trick your body into thinking you're interfacing with a primary infection. And of course, that's the principle that underpins vaccination. You vaccinate either the whole pathogen that's dead or alive, or part of it, or part of it's conjugated to prime your body into an active immunization. And then even though you haven't had the interface with the actual bug itself in the real world, your body has been stimulated to recognize that structure of that bug, so that when you do then face it for the first time in the world, you've got a whole cadre of sophisticated secondary immunity memory that prevents you getting a severe response to that infection. So there's lots and lots of different vaccinations that have been very, very successful over the last 40 or 50 years. I don't really want to spend too much time because it's quite dry, and I also don't think you'll be able to remember it at 20 past 10 at night. But this is the current UK schedule, and this is all of the different viruses and bacteria that we vaccinate against. I guess the most notable thing that's just changed in the last few months is that we've gone from the MMR to the MMRV. So we're about to add in the varicella vaccine component to this schedule, which will mean that children will be getting vaccinated against chickenpox, and we'll see a significant reduction in that disease. This is one of those things that I remember as a medical student, you just sadly have to go and learn about. There's just no real way of doing this apart from rote learning. And I know that certainly in the UK schedule, in the UK examinations, it's a very frequent thing to be asked about. So whilst it's very dry, it's worth probably revisiting the UK NHS and I guess relevant Palestinian schedule for your vaccinations in country as well, because they'll probably be different to this. So I'm just going to talk through some of the kind of common clinical presentations of these diseases when you don't have the vaccination schedule itself. So this is diphtheria. So this is part of the DTaP vaccination schedule that we've got. This is a disease that's caused by Corynebacterium. It's droplet transmission. The characteristic feature of this disease, which is fairly rare now, thankfully, due to vaccination, is a kind of very persistent tachycardia, but without high fever. You get this awful membrane formation on the left back tonsil. It can have a kind of very thick membrane formation. It's really quite hard to get scrapings from. People have very husky, brassy coughs and sore throats. The important thing to look out for with diphtheria is you can end up, after the acute throat infection, getting a secondary myocarditis that can be very, very problematic. People end up very, very hypertensive, and there's been multiple cases of children dying with unrecognized secondary myocarditis. Other less frequent complications include peripheral neuropathies and encephalitis. The treatment is penicillin alongside antitoxin for the Corynebacterium itself. This is sadly tetanus, and I was in Nepal. There was actually a whole ward of children who were suffering from acute tetanus. You can see that classical opsotonic presentation. It's caused by Clostridium tetani, which is a soil-based pathogen, and it basically has this very, very fascinating ability to produce neurotoxins. It then causes secondary neuromuscular blockade. So you block because of that block of the horn, you end up with a secondary muscular spasm and autonomic dysfunction. It's a very, very sad disease to see because you get this very profuse opsotonia. As I say, you can get upper respiratory involvement that can lead to kind of progressive respiratory failure and death. If you have a child who has exposure to soil contamination and you're not sure whether they are or aren't vaccinated, please be sure to just immediately give them vaccination. And then if it's feasible in your setting, tetanus immunoglobulins and alongside that, metronidazole for the secondary anaerobic infections. Sadly, if you get to the point where you've got a clinical presentation of tetanus, you've missed the window to prime that immune response to prevent that infection. That being said, there are supportive things you can give, such as benzodiazepines, which can help with the kind of spasticity. And sometimes children do survive when they're intubated and ventilated to get through that respiratory failure, but it does carry a high mortality. This is just a point about cultural behaviors, and there's practices in parts of sub-Saharan Africa where people would, when children were born, spread actual soil based around the umbilicus, which is a very, very dangerous practice given the risks of inducing tetanus in that infant. I'm just going to show you a video which is slightly terrifying, but an important presentation for you to recognize.
Yeah, here. You got it. You got it. You're okay. You're okay. You're okay. That out. Spit it out. What you just coughed up, spit it out. Spit it out.
So that is a slightly startling presentation, which I suspect if you haven't seen, it's quite worrisome, but it's very characteristic of a disease called pertussis. So again, part of that DTaP vaccination schedule. So bordetella pertussis often starts that classical kind of coryzal presentation, but then within a week to 2 weeks, you end up with this kind of paroxysmal, violent coughing episodes like you just saw with that young girl. It's a characteristic inspiratory whoop. Children often cough so much and they've got so much distress, they end up vomiting. Young infants in particular have really high risk of apneas. And there's a really interesting phenomenon where they can end up with a very significant peripheral blood lymphocytosis, which can become so marked that you actually end up having to do plasmapheresis and blood exchange transfusions because otherwise you become hypercoagulable and at risk of kind of vascular events and death. It's very treatable with a macrolide, and of course, in the UK schedule, we now vaccinate mothers to give transplacental protection of the infant. So it's become less frequent, although with vaccine hesitancy, we have seen outbreaks of pertussis in the last 10 years in the UK. This, very sadly, is a child who's got significant presentation of polio, as you can see, with that hyperextended lower limbs. It's a part of the poliovirus, which is within the enteroviral family. It replicates in the intestine, and it's a very classical fecal oral transmission virus. Most cases are asymptomatic. Some have some minor upper respiratory infections. About 5% get central nervous system infections. And it can give you this very characteristic, you're probably mostly aware of kind of paralytic presentations. And it's because of the destruction of the anterior horn cell. You get a flaccid paralysis, hyperreflexia, muscle wasting. And for some reasons, it isn't really fully understood. The legs seem to get much more severe disease than the arms. And you can again get this kind of evolving respiratory involvement and respiratory failure. Okay, then so that's the kind of classic vaccinations that I've just covered from as of this part of the schedule, so the DTaP. Now we're going to go into the encapsulated bacteria that have also had huge reductions in their incidence and prevalence due to conjugate vaccines in the last 20 years. So this is the polysaccharide capsule. I'm just giving you the example of why these bacteria are so sneaky. They have this complete coverage with this sugar-based structure that means that they can actually evade the immune system. They're much harder to recognize. And because of that, you really need additive parts of your immune architecture, such as complement, to recognize them and stick to them, and then stimulate other parts of the immune system to then come on and attack them, including the spleen. So the three commonest encapsulated bacteria that you need to know about, if you don't already, are Haemophilus influenzae, which can give you sepsis, meningitis, pneumonia, historically that very terrifying epiglottitis that we see very frequently now because of vaccination. Pneumococcal disease, so Streptococcus pneumoniae, again, can give you sepsis, very severe meningitis, pneumonitis, pneumonia, acute otitis media. And then Neisseria meningitidis, which gives you that septic picture or meningitis picture, or actually often both in the same presentation. So, Hib, this is a kind of terrifying case of a child you really don't want to ever interface with in your life, who's got essentially partial airway obstruction because of this awful inflammatory process that's going on in their epiglottis. They can be very, very toxic. They look very panicked because they're acutely aware that they're struggling to breathe. They have this characteristic tripod-like presentation where they're holding their arms rigid to trying to maximize their airway capacity. And they are at high risk of acute respiratory failure and death because of the vulnerability of that airway. And so you're never meant to examine them, you're never meant to put cannulas in them. You just need to get an anesthetic consultant or more than one to come and support their airway, because that's going to be the most important thing acutely. Okay, pneumococcus, commonest cause of various different evasive bacterial infections, but with the advent of the PCV, originally 13, now 15, now 18. And by that, I mean that's 18 of about 100 serotypes that are covered in the vaccine schedule. We've seen significant reductions of community-acquired pneumonias, meningitis, bloodstream infections, but it still circulates in high numbers. We've seen lots of epidemiological studies that have shown, whilst there's been reductions in the vaccine preventable serogroups, these have been replaced by the non-vaccine serogroups. So the disease still causes a significant burden, and you need to give boosters, particularly in those that are immunocompromised or have hypersplenism. Neisseria meningitidis, you'll be very aware of, is this is the kind of classical terrifying story that you hear in the newspapers or on the TV. Thankfully, it's become vanishingly rare. Earlier on in my career, I probably saw 15 or 20 cases of this, but I haven't seen a case in the last 2 or 3 years because of the success of the vaccine schedule. It can cause bacteremia, sepsis, meningitis, like I said. It sadly is a very, very rapidly evolving disease. So if you have a child who has got a non-blanching rash, you have to act absolutely immediately, because even when you do, unfortunately, you end up with this kind of disseminated DIC picture quite frequently, and high proportion of these children end up losing one or more limbs and often have very significant central nervous system consequences as well. Now, thankfully, there's vaccines that have been put in place. One of my colleagues, Andy Pollard, has been instrumental in implementing the meningococcal B vaccine schedule in 2016, and that's now not only reduced transmission of meningitis B, but the other serogroups, and by that I mean A, C, have also been significantly reduced. So there's some cross-class effectiveness from this vaccine as well. There were outbreaks of meningitis in UK teenagers, particularly children that were going to university and interfacing with other children from other parts of the country with completely different immunology and nasal carriage of these bacteria. And so because of that, there's been ACWY that's been added into the vaccine schedule in the UK to try and protect against that late teenage onset meningitis in that at-risk population. These data are just to illustrate that you can see, obviously, as we've had the introduction of the MenB vaccine in 2015 in the UK, there's been a reduction in the numbers of cases of MenB, but you'll also see there's a reduction in the number of other non-B type meningococcal serogroups. So there's definitely some cross protection across the strains, which is very, very beneficial. This is a child who has got Koplik spots in their mouth. As you can see, that's a characteristic pathognomonic feature of measles. It precedes the kind of characteristic cough, coryza, conjunctivitis, and macular-papular rash that typically starts behind the ears and spreads to the body. You get with measles, so it's not very frequent you will spot the Koplik spots. I've seen it a couple of times, despite having seen many, many children with measles. As I say, that's the kind of prodrome, the cough, coryza, conjunctivitis, and the rash behind the ears, and that is a very true presentation you'll see most of the time with this this virus. It starts off kind of very patchy, and then it becomes more increasingly confluent as a rash as the days go on. Again, like many of these diseases, for the vast majority, it's a self-limiting, albeit fairly unpleasant, febrile illness, but there are complications. So you can get significant pneumonia secondarily. Occasionally, children get secondary bacterial infections. Encephalitis is definitely a problem in terms of acute encephalitis. So measles, primary infection, but very sadly, you can also get this very catastrophic, still not fully understood immunologically why, disease called SSPE, so subacute sclerosing panencephalitis, which is very much a disease that happens up to 10 to 15 years after the primary infection, which is unfortunately completely irreversible and fatal. Sadly, in our setting in the UK, because of vaccine hesitancy, we've seen significant increases in the numbers of outbreaks of measles, despite it being a completely preventable disease. In the UK, it was deemed to be essentially we were almost free of the disease. And then because of areas of the UK having reduction in uptake of the vaccine going from 90 to 65%, we lost that herd immunity. And then we had these significant outbreaks of cases, both in the sort of 2012-13. I was actually working in Liverpool during this time. We actually had entire wards of children with acute measles. And then we've had similar outbreaks in the last year as well, which is really sad. Of course, vaccine uptake isn't simply vaccine hesitancy or vaccine skepticism. There are populations of children that are just very hard to access in our setting, particularly with the increase of immigration. There are just very fragile families that are often very hard to access in the UK, and that leads to reduction in vaccines to those that probably need them the most. There are also people in the UK who can't have vaccines if you've got specific contraindication because of primary immunodeficiency. And of course, there are children who are at risk because not that they're vaccine hesitant, but they're at the age where they maybe have only had one dose of their vaccine. This is a child who's got mumps. I have to say, mumps is obviously part of the MMR and soon to be MMRV vaccine schedule. We don't see it very often. It's this classic parotid presentation, very limited, self-limiting on almost all cases. You can get a secondary meningitis picture, but it's very rare. For most cases, it's just a very painful presentation. It needs lots of analgesia and fluid. You can get orchitis and sterility as a secondary consequence, but again, that's a fairly rare picture, and you can get rare things like pancreatitis and arthritis. This is rubella, which to all intents and purposes to me looks very much identical to measles. Again, we see very little of it. It doesn't have the same transmission. It's not airborne like measles is, and with the vaccine schedule, it's managed to be kept at bay, even with those lower uptakes nationally of vaccine uptake. It gives you an almost identical presentation, although the rash doesn't start behind the ears. Typically, it gives you that maculopapular rash, and it can give you arthralgia as a secondary consequence. You give everyone the vaccine. The reason, like many vaccines in children, you're giving the vaccines to the child not to necessarily primarily protect the child, although you're happy to do so. It's to protect those other people that interface with the child that are increased in vulnerability for more severe disease. So in the case of rubella, you vaccinate. Yes, you prevent childhood vaccination disease of rubella, but you're trying to prevent women who are childbearing getting the disease because of this catastrophic presentation of a disease called congenital rubella syndrome, which gives you significant different phenotypes, which include lower birth weight than expected, significant retinal changes, cataracts, visual impairments, sensorineural deafness, and this characteristic buff blueberry muffin-like presentation where you get these actual deep lesions throughout the body, and they're often found at post-mortem in children who've been unrecognized to have been born to a mother who had a quiescent rubella infection during pregnancy. Okay, chickenpox itself, as I say, it's a very highly infectious airborne disease. By 10 years of age, 90% of children have had it. It can give you secondary complications, like I've already talked about. There are people who are at increased risk of more severe disease. Pregnant women, you can get congenital varicella disease. So neonates, those that are immunocompromised, so those that are being treated for oncology with therapeutics that reduce their ability to fight the infection. So there's certain populations that you want to avoid. So there's children that have got chickenpox, they must avoid interface with those at-risk populations. And the vaccine schedule is, as I say, being introduced in the UK in the next few months as we get into 2026. I'm conscious of time, so it's 10:30 now. I don't know what people want to do, whether you want to finish now. I think there's just a few more slides on vaccines and the kind of principles of vaccines, but I'm happy to, this kind of covered most of it. If we want to finish here, or if you want me to just do the last few slides, I'm happy to.
People in the chat have said they're happy to continue.
Yeah, have they? Okay, fine. Okay. Okie doke. Right. So cervical cancer has been one of the biggest kind of public health benefits of the vaccine schedule in the last sort of 15 years. So cervical cancer in 99% of the cases is driven by a virus called human papillomavirus, and specifically two individual serotypes of HPV, so type 16 and 18, cause 3/4 of cervical cancer. And there's now been a vaccine that's been introduced in the UK, and the data is astonishing in terms of reduction of cervical cancer in teenagers and young women since this introduction. And so 10 years out from the original introduction of that vaccine being put into the schedule, it's caused more than a 90% reduction in women getting the disease, which is absolutely amazing. Similarly, rotavirus used to be our kind of most common viral disease that caused gastroenteritis in infants, and in low middle income settings, like I used to work in Malawi, you would get significant numbers of deaths from this disease. This has been introduced, I think, 2012, 2013 in the UK, and it's just completely plummeted the number of cases. We very, very rarely see rotavirus anymore. One important point to remember about rotavirus vaccine is you give the first 2 doses 4 weeks apart, and you've got to be under 3 months. If you, for whatever reason, miss your schedule and you don't get the vaccine within the 16 weeks in which you're meant to, i.e. within the first 4 months of your life, you don't give catch up later, because there's quite a well described secondary risk of intussusception, which is invagination of the bowel, which can give you an acute bowel obstruction and secondary perforation. So that's one quirk of that vaccine. Hepatitis B is really important as a vaccine, because it can have very, very profound effects in children. Whilst only sort of 10% of adults that contract hepatitis B acutely go on to develop chronic disease, actually more than 2/3 of children who get hepatitis B end up with chronic disease. And if you get it as a neonate, you're almost certain to get chronic liver disease because 90% of you will end up with a chronic hepatitis-like infection. It can lead to progressive liver failure with cirrhosis, and that can significantly increase your risk of hepatocellular carcinoma. So if all mothers get screened for hepatitis B during pregnancy, and if a mother is found to be hepatitis B positive during a pregnancy, then the baby gets birth vaccine a month and a year to stimulate antibodies, and they will get pooled immunoglobulins if you're at high risk of infection, i.e. if the mother is hepatitis B surface antigen positive, i.e. she's in the acute phase of her hepatitis B, and then for transplacentally giving huge amount of burden to the infant, then that child needs to have pooled antibodies as soon as they're born to try and fight that infection to interrupt the risk of long-term hepatitis B infection chronically. Okay, so everyone should be vaccinated essentially, because what you're trying to drive is this kind of concept of herd immunity where you prevent infection in yourself, yes, but if most of the people in your community have got the same vaccination schedule, you interrupt transmission so much that you prevent even those that are unvaccinated getting infection. So a bit like with COVID, if you think about it, when we were all unvaccinated with this primary new infection, we were just constantly having sustained transmission. One person got the infection, they had no ability to deal with it immunologically, so the next person was transmitted to it, and the next, and the next, and the next. However, if you think about it in very basic terms, if someone who's got a case of infection and then they try and transmit to someone that's immune, and then that all of a sudden just blocks that onward transmission. So that's the principle you need to think about with vaccination. Yes, it's for yourself, but at least importantly, it's for the population that are at risk. There are specific vaccination contraindications. They're less frequent than you think. Everyone worries about being anaphylactic to a specific type of vaccine. Almost never to be the case, but if you do have described and documented anaphylaxis, of course that prevents you being able to have the vaccine itself. However, the far more common clinical scenario is that you've got a child who's a bit unwell, who goes to the GP and they think, oh, I better not have it because my child's got a cough or a cold. That's not true. If a child is unwell but they're not febrile, if they're just cries and snotty, they should have the vaccine. Because of the frequency of these types of benign infections, you don't want to go on and keep delaying the vaccine schedule for these children. So get on and vaccinate. However, if you've got a true fever that's documented of over 38, that's probably not a sensible time to give a child an infection. Not that it will make them feel worse particularly, but it will probably dampen the ability of the immune system in response to the vaccine, i.e. a child that's got an acute fever is unlikely to mount the same immune response to that vaccine you're trying to stimulate them against. So you may end up with an ineffectual response to the vaccine, which seems completely counterintuitive. Similarly, you're not meant to give vaccines to children that have got undefined neurological conditions, simply because you don't want to obfuscate the concern about vaccination having anything to do with that. The more likely things, the vaccinations you're going to see all the time when you vaccinate children in your settings, is to get local erythema, pain, swelling, but that's kind of part of the whole deal. You're trying to induce an immunogenicity, and part of that will be a local inflammation, and you can tell parents to anticipate that, and actually they can go so far as having the ability to give paracetamol around the vaccine so that they end up with less pain and less inflammation and less swelling. Anaphylaxis is vanishingly rare. People worry about it. We get children into our ward, into our clinic all the time. I've never actually seen it. I know it's described, but very, very rarely. There was also previous concerns about allergies to egg components, the MMR, that have been now kind of disproved, and we don't need to worry about that. But that was a big fixation for a lot of people for a very long time. I don't really want to spend too much time about anti-vaccination, except to say that it is clearly an issue. Yes, the children who are born to families who fundamentally oppose vaccination, it's really hard to try and actually dig into that. People are always very skeptical. They come with a very significant skepticism, but it's our duty as clinicians, I think, to at least open a conversation, because often if you really can do it in a tactful way, you can find that there's one or two or more reasons why there is skepticism. So as clinicians, we should be vaccine advocates, and it is our duty to not just ignore it or get frustrated about it. It's our duty to rather explore the hesitancy or refusal and try and open a dialogue, because it can be fundamentally important to preventing severe infection in children. There's lots of history towards a lot of this. Of course, currently there's lots of misinformation on the internet, and there's lots of highly powerful political figures who are driving forward misinformation. But this isn't a new problem. The original story with MMR and autism is probably one of the main examples of where things went wrong, where there was a very, very, very poorly conducted study of a very small number of children and flawed science using self-report from historical cases of families. And there was a very, very unfounded association found between autism and MMR. And the consequences of that are still lived today. There's been multitudes of children who've died internationally with measles invasive infection unnecessarily. And so we know that it doesn't take much to tip the perspective of people surrounding vaccines. There's other history around this. So, for example, for a period of time in the late 90s, people were very worried about the amount of mercury there was in vaccines, and that this might be associated with neurodevelopmental and autism outcomes. Again, this has been completely disproved, and the amount of mercury there is in vaccines is far lower than what we eat in our fish. So I guess a kind of last point to make before I finish is, alongside all of our other duties, if you have families who are hesitant about vaccine schedules or resistant to it, take the time. It is arduous, it is exhausting, it doesn't always get you where you want to go, but you can offer people information about specific sites such as the British Society for Immunology give you vaccine schedule history and information, and it can be layperson by documentation. Our research unit, the vaccine group, the Oxford Vaccine Group, actually have got a whole vaccine knowledge website that you can refer people to allow them to digest this information in their own manner. Okay, I'm going to finish there because I'm conscious it's really late where you are. I just wanted to say thanks for listening at this time. The other thing to say is, if you want any other topics, we've got a number of us in the group that can give you other lectures on acute infectious diseases. So if that's of help at any point, just let me know. Carla, is there anything you want to say?
No, thank you so much for that lecture. That was really helpful. I think I'll keep an eye on the chat in case anyone's got any questions, but I think generally people can just message or
Fine.
email us to see if they've got any requests, and we can let you know.
Fine, that sounds great. That's okay. I'm glad. Sorry it's so late, but I'm glad we got there. Thanks so much.
Thank you. I'm going to stop the recording now as well.
Yeah, sure, no problem.